My guest today is Dr. Juan C. Suarez, an orthopedic surgeon specializing in adult hip and knee joint replacement at Baptist Hospital in Miami, Florida. With over 16 years of experience in his specialty, Dr. Suarez focuses on primary and revision joint replacements as well as minimally invasive surgical techniques. He serves as an affiliate assistant professor at Florida Atlantic University Charles E. Schmidt College of Medicine and on the editorial board of Arthroplasty Today. He is a member of the American Academy of Orthopedic Surgeons and the American Association of Hip and Knee Surgeons, and has over 1,000 patient reviews with a 5-star rating. Dr. Suarez also happens to be my surgeon, the one who replaced both of my hips. Lastly, Dr. Suarez is married to a Polestar Pilates graduate. In this conversation, we explore when hip replacement is truly indicated and when it's not, why x-rays don't always tell the whole story, and the surprising statistic that 80% of hip arthroscopy after age 50 leads to replacement within 2 years. We discuss what actually causes hip degeneration, how to find the right surgeon, and why communication understanding a patient's goals may matter as much as surgical skills. We also bust a few myths about what you can and can't do after getting a new hip. Welcome to the Live Aligned podcast. I'm Dr. Brent, a doctor of physical therapy, professor, founder of Polestar Pilates, and pathokinesiologist. For over 35 years, I've been fascinated by the dynamic relationship between movement and pathology. On this podcast, I'll host special guests and friends who are making meaningful contributions to help us live aligned and be kind. 35 years ago, I founded Polestar Pilates with a mission to bring intelligent movement to the world. Polestar graduates are trained to work with the individual and optimize performance. If you've been looking to optimize your health, find a Polestar Pilates graduate near you. Go to the Polestar Pilates website, click on Find Your Graduate, and search for a professional in your area. And now, my conversation with my colleague, my surgeon, and dear friend, Dr. Juan Suarez. Thanks for coming on the Live Aligned podcast, Dr. Suarez.
Thanks for having me, Brett. Appreciate it.
You bet. You know, the whole idea behind the podcast is really to give our listeners a chance to, one, get educated, and two, to remove fear. And I don't know if you remember or not, Juan, but I had gone to like 8 different surgeons around the world looking for the best MATA procedure on the newest HANA table with the latest robotic things. And I'd gone to Chicago, I'd gone to New York, I'd gone to Colorado, I went to California, and I just wasn't feeling it. And I walked into your office in my home in Miami, and we sat there looking at the x-rays. And you sat next to me instead of over me, like a lot of the surgeons did. And you asked me a question. And you asked me, what do you need to be able to make this decision? Because we were looking at the x-ray, but you just asked me that question. I said, well, I want to be whole body. Like I've already lost enough parts and things in my body. And you had mentioned that you had heard me talking in some of my lectures when your wife was studying Pilates with us at Polestar, and that I believed in whole body function. And we sat there, and I got a little emotional because I felt like this is the first time we're actually talking about this. And it was just like in that moment, I knew you were my guy. I knew you were my surgeon. And we had a lot of success with that surgery and the second one 2 years later. So I want all of my listeners to be able to have that kind of experience. You know, and I think a lot of times when they just get an x-ray and they go in and they're told they need a total hip replacement, and the next thing you know, they're on the OR schedule like 4 months out or whatever it is. I would love for them to be educated. And just again, for everybody to know, Dr. Suarez is a lead surgeon for total joints at Baptist Hospital in Miami, Florida. And also you were for a while in, what's the name of the
Cleveland
hospital?
Clinic.
Cleveland Clinic, that's right.
Yeah.
And your reputation has continued to blossom. I did a little background search. Like, you have a 5 out of 5 stars on 3 different things with over 1,000 people commenting on it. And that's just not the case where you have that many happy people. So there's something you're doing very well. Of course, I'm one of those that is very happy. But tell us a little bit about yourself and a little bit about your background. What's your focus these days in total joint replacement, where your passion lies and applies to us that are potential patients?
So first of all, thanks for those words. I mean, I think that you kind of hit the nail on the head in terms of, it's amazing how physicians don't talk to patients. It seems like that's a very common complaint. And part of what defines me is my Hispanic background. So I kind of fit perfectly in Miami environment. So I really am able to connect with our multicultural community. And part of Hispanics is that we're very talkative and we like to communicate and we're very friendly and social. So to me, that aspect is kind of like natural to me, right? Communicating with people, connecting with people. And that's kind of an aspect that I love about what I do. Like you said, I was at the Cleveland Clinic for almost a decade. And then I had this opportunity come up at Baptist in Coral Gables, which is really where I was living. I was commuting to Weston to the Cleveland Clinic. So to me, it was a very natural progression. And it was not an easy decision, but it was kind of the right decision because I was going to be home, close to home, and a lot more available to my family. So I've been there since 2017. And it's been great. I mean, my practice, luckily, I already had a good following from the Cleveland Clinic. My personality and my background fitted perfectly in Miami and in that community. So I've been very successful. I continue to build my practice in Miami. And I, like you said, I dedicate to do only hip and knee replacements, either primary or revision surgery.
It's funny is you say that about being Latin or in the Hispanic community. And I think I like that same reason. It's like, when something comes up, I don't ever want to abuse it. But if I need to get a hold of somebody, it's like, it's responsive. We can talk, it's direct, it's face-to-face. There's no condescending kind of talk. That is something that I teach in the university for the physiotherapist in their professional formation is like, how do you learn to engage in a conversation with your clients or your patients? And that being able to get them to tell their story is important.
Yeah.
And we get a lot more out of it. Like, we understand where they're coming from. What is it that this person thinks they're going to be able to do after having a hip replacement? Or what is it they think they can't do because of their hip pathology that immediately gives you insight as to how successful your intervention is going to be or not. It's amazing how fast we can get that information out.
And it's interesting because I remember we had lunch a couple of times after your surgery. And one of the things you said resonated with me. And it's like, you need to understand people's goals and beliefs, right? Sometimes people come see me and there is no chance in life that they'll go under the knife. That's just not in their wheelhouse. That they don't want to think about that. And it's just about being curious. So how do you want me to help you? How do you see this evolving? And it's... And you learn from patients as much as they learn from you. So it's just a matter of kind of learning people's background and kind of where their head's at. Like now, a lot of the times I ask patients, where's your head at in terms of your hip or your knee, right? You got to guide me a little bit because I don't know where you are in this journey.
Yeah.
If you're in the beginning of this journey, this conversation is going to go in this direction. If you're kind of all the way at the end of this journey, we may go in a different direction.
That's such a good point. Even with the knowledge base that I have in rehabilitation, I was still, and I think it's important for everybody to understand, I was still going through my inquisitive journey of whether I was ready for a total hip replacement or not. Think about when we talk about getting a brand new hip or getting a hip replacement or a knee replacement, the threshold of when to do it is changing. And it used to be, we would say something as a physical therapist, we would say, when you can't do 80% of your activities, get a knee replacement or get a hip replacement. That's changed. That's changed a lot now.
Yeah, well, I think you got to separate hips and knees. I think
True.
hips, the threshold is a lot lower now because
So successful.
know it's such a successful operation that the likelihood that you're going to end up with a very happy patient is very high. Knee replacement is a little bit different because, we're changing in knee replacement, whether we like it or not, we're changing the anatomy significantly. And there's a period of adjustment that the patient goes through. And that period can be pretty long. So that's why it's a little bit different in terms of the threshold. But we're definitely pushing the envelope. We have new technology. We're using better implants, better materials. And we are seeing that those materials last longer. So we're emboldened by that data. So we're pulling the trigger a little bit earlier than we used to.
Well, I think, if you take movement away from somebody, it's sort of like a death sentence, when people stop moving because of their pain. So let me back up a little bit and just introduce a couple things. That one, I sort of labeled this discussion as the $6 million hip, basically wanting to say that we do a deep dive with Dr. Juan Suarez into the realm of total joint replacements of the hip and the knee, and how the new hip can be life-changing, but we need to be able to go through the journey and ask the right questions. We need to be able to get the right information, find the right doctor, find the right procedure, and know that it really is time for us to make those decisions. In this podcast, our goal is to be able to educate into what actually is going on, what is the science behind it, what is the indication for it. Indication means that, when do you know it's right? When is it right to get a total hip replacement versus maybe not? And I know that I've worked with Dr. Suarez with a number of patients that I've sent there, and they weren't quite ready. It wasn't time for them to have the replacement, which I also respect a lot, Dr. Suarez, in being able to know when that is. So a couple of things that we want to accomplish today in this podcast is learning about the surgery, and even before that, learning how do we prevent hip degeneration. And I think a lot of times people just get scared because if you're over 50 years old and you get an x-ray, you're more than likely going to show some signs of degeneration if you've been active in your joints. If you're 60, it's more, and if you're 70, it's even more, whether that's the problem or not. And then talk a little bit about the aftermath of the surgery. And I've got a couple myth busters that I'd like to present to you as well, and then we can wrap it up with any thoughts that are left over.
Perfect. Let's go.
So let's jump into some common questions, Dr. Suarez, that come across the table all the time. And I know you hear it all the time. I hear it all the time from my patients. Most of my patients are asking whether I think that they should or shouldn't. Is it time for them to have a total joint replacement? And we see it all the time. So let's start off with the question, why does the hip degenerate? Like, why do we see this? The knees as well. We can focus a little bit more on the hips today, but what is that takes place?
So when, us surgeons, when we talk about arthritis or degeneration of the joint, what we mean is that the cartilage or the cushioning of the joint wears out. And as it wears out, then you don't have any cushioning left. And then the joint starts rubbing bone on bone, and that friction creates pain, inflammation, stiffness. Now, the reason for that could be from different reasons. For example, it could be from trauma, like in your case. You had what we call post-traumatic arthritis. A traumatic event led to dysfunction of the joint, which led to degeneration of the joint. You can have an autoimmune disease like rheumatoid arthritis or lupus, which basically your own body attacks your joints. And that chronic inflammation breaks down the cartilage. There's also people with anatomic variations like dysplasia of the hip, where the socket of the pelvis is not formed completely, so it's shallower. So what happens in those situations is that there's abnormal stresses on the joint, and those are normal stresses over years that leads to degeneration of the joint. But the most common one is osteoarthritis, which is basically what we call wear and tear. And we really don't know exactly the etiology of it. We think it's a lot to do with genetics. But basically, your joint starts breaking down over a period of time. And then again, the cushioning breaks down. You start rubbing bone on bone. And then you end up with an arthritic hip or knee for that matter.
So mythbuster number one is, do you need to see the cushion gone to justify the surgery, or are there times when you'd go ahead with the surgery even if you didn't see the bone on bone? Would there ever be a reason to do that?
So there's data, especially on knees, that try to correlate different variables to unsuccessful results. And one of those variables is the knee not being bone on bone on x-ray. Meaning if you pull the trigger too early, then you may be paying the price for that. Now, there are situations, for example, on the hip where you can have osteonecrosis of the hip, or, in the same way you can have a heart attack, you can get that in the hip and it's not bone on bone, but there's a different process going on the bone.
And just to explain that necrosis is where tissue dies. So if the artery that goes into the head of the femur is damaged to where there's no longer blood getting there, no blood supply, the bone's dying, and that's going to be a problem. We've seen that with a number of professional athletes as well that have had major trauma or dislocations and ended up with avascular necrosis in the hip. So,
but a very common scenario is people are like in the twilight zone, right? They're not bone on bone. They come with an MRI. The MRI of the hip shows a labral tear, mild arthritis. You examine them, it's an intra-articular pathology that's causing the pain, but you're like, well, I don't think you're ready for a hip replacement. And a lot of people fall in that category. And the question is, how can we make them better and try to prolong the life of their normal hip?
Let's use that as a case. Like somebody comes in, like maybe me 20 years ago. Would you refer them to somebody that is doing arthroscopic or to rehabilitation? What would be your backup plan?
So we know that if you get a hip arthroscopy after 50 years old, the conversion to a hip replacement within 2 years is about 80%. It's super high. Yeah. So.
Oh my gosh. So
you have to be very careful. I see that a lot in my office. A 52-year-old guy that gets a hip arthroscopy, he's still miserable, hasn't recovered over a year because that patient already had arthritic changes in the hip. And the arthroscopy is not going to be a game changer, right?
And just for everybody to know, arthroscopy is where they do a minimally invasive scope that goes into the joint. And I've been doing it for knees and shoulders for as long as I can remember. But the hip was really starting around 2000 to start seeing it as a common ground to go in. But I had no idea that the incidence over 50 was that high.
Yeah, a hip arthroscopy in a patient over 50 years old, you have to have a very specific justification for it.
Yeah. I mean, because, in the population I worked with for so many years with the dancers, they had the shallow hip. So that was already there. Of course, you married one.
Yeah.
So you know better than anybody.
Oh, God.
But, it's like you work with these dancers and you realize that they have a shallow acetabulum. The acetabulum is where the socket is coming in. And it's like you said, if it's shallow and there's a little bit of a deformation, and for that classical ballerina, if they're Balanchine based, we're looking, they have a retroversion. That's where the femur naturally spirals out. So they're like perfect for Balanchine, right? They're perfect for ballet. You try to walk normal in those hips and, you're at the end of range and there's no internal rotation. And so, they're putting increased stress on the cartilage and the tissues in the hip. And we do see them even as early as 40s and 50s getting total hip replacements quite often because of the specific, situation where their hip deformity, the athletic activity that they're doing as a ballet dancer, and the intensity of the dancing that they did. Yeah. Interesting. I'm still blown away by that statistic. Over 50, 80%. It's like just blows me away.
Yeah. And, and the problem is, like, for example, you use the ballerina example, right? But the problem with those patients specifically is if you get an x-ray on them in their 20s, you know the operation that can prevent them from having a hip replacement, which is pelvic osteotomy, where they reshape the socket. But who's going to convince any human being to have a huge operation when they don't have pain or anything like that, right?
You know, I just met somebody the other day that is a physical therapist, had huge genu varus, more than I have, and decided preventatively to go in and have the tibia and the fibulas both fractured, osteotomies, with looked like a Lizaroff kind of apparatus, external fixators on both legs, and ended up with multiple severe infections that left him immobile for 5 months. He's finally okay. He's doing okay. But I've never seen that. I mean, I hear about osteotomies, but this one I saw and looked at and was like, yeah, no, I think I'd rather have Juan do a total knee on me than...
How old is he?
I would say he's probably either late 40s, 50.
Wow.
You know, so he's been with that varus. Varus, by the way, is bow-legged, the common term for that. So, you know, where your legs look really round. And those of you that know me on this podcast or ever seen me walk, you know that's varus. I am varus in vivo. But what a thing, right? To think of doing that. And you're right, of a hip. If you had told me when I was 21 dancing that I should have my acetabulum reorganized, and I don't really have that problem like a lot of dancers do, but I would say, like, are you crazy? What a huge surgical procedure. You know, the other side of this too is looking, and this is one of those myth-busting questions of hypermobility. So people that literally have excessive hypermobility, maybe they're borderline Ehlers-Danlos. I don't know what your thoughts are on that.
You know, those patients, the challenge they present is instability. Patients that have, you know, pseudo Ehlers-Danlos or some type of collagen issue where they're very, very flexible, instability, or that the hip comes out of the socket, is higher. And on those patients, sometimes we use different or alternative implants that are more stable to try to prevent that from happening. Because there's not a test that tells you, well, this person has like kind of a collagen type disease.
There's no genetic test for Ehlers-Danlos, hypermobility.
Exactly. There's no test for that. So it's just a matter of like examining the patient, and you're like, well, this patient is very hypermobile, and try to prevent the problem from occurring.
Well, I think that's what Mark Philippon was trying to do. I mean, he knew my history. He took a lot of information, and he consciously did some microfractures to get the bleeding on the head, and had removed the labral tear because there was no repairing it, and did the thermal shrinkage on the capsule, which you had to go in with a chisel and knife to try to peel off.
Yeah, so for the audience to understand what we're talking about, so Brent's hip, when they did the arthroscopy, they used a heating device that shrinks the capsule in an attempt to make it tighter. But for what that does when you go back and do a hip replacement, it makes everything very stiff and sticky. So it makes the surgery of the hip replacement a lot more difficult. I remember after the surgery, I told Brent, oh my God, that was not easy.
You earned your money. You earned your money on that surgery.
Because the capsule was all shrunken and stuck down to the bone.
Well, and I think that what would be interesting is comparing how the left side was that did not have any other surgeries that were repaired 2 years later. So just for the audience to know, Juan has replaced both of my hips. I have identical hardware, identical surgeries, identical surgeon, but I'd never had any arthroscopic or medical procedures in the left hip. But I still lost a lot of the capsule because it was so damaged. Was it damaged because it was like stretched out, or what do you think?
Yeah, what happens a lot of the times as you develop arthritis, you develop bone spurs or osteophytes and synovitis or inflammation of the capsule, and that starts stretching out the capsule because of all the synovitis and everything. It starts like, it basically sometimes gets like almost paper thin sometimes.
Interesting. Well, listen, let's jump into some methods that are out there. And I still get shocked to hear of somebody asking me, should I get this posterior approach versus an anterior or anterior lateral approach? Again, sort of myth busting, but what's the story these days amongst you as surgeons that are replacing the hips, like, is the old school working its way out?
So when they started doing hip replacements, the original approach, what's called transtrochanteric approach, meaning they would cut part of the femur bone and they would get a really great exposure, and then they would fix that piece of bone back to the femur. Then that fell out of favor, and then it went to a posterior approach, which meant they go through the back of the joint. So they enter the joint through the back of the hip. So in order to do that, they have to detach all the muscles on the back of the hip.
So all the rotators.
And that was that was a very successful surgery for a lot of times. And then some guys in Europe and eventually in the US started doing what's called an anterior approach. And that approach was used for acetabular fractures before. So they adopted that to the hip replacement, which is an approach basically where you don't have to cut any muscles to get to the joint. You're basically working between the muscles.
Yeah, a dissection.
The dissection is between muscles, is not through muscles.
Mm-hmm.
And it's a harder operation to do because exposing the femur to work on it is harder. So that's why a lot of people shied away from it. But obviously when people see that something works and they start publishing their results, then, people start doing it. There's more research behind it, more technology, more innovation. And the technique has been perfected over the last 15 years.
Yeah.
And in the American Association of Hip and Knee Surgeons, you can see that every year they poll the audience to see what the percentage of people are doing anterior approach. And
what do you think?
It's over 60% now.
Yeah.
So this is gaining traction and there's no turning back.
Now, do you think this is like everybody is studying what Matta and that original group of surgeons sort of brought to the table? Are they all using the HANA table like you did? What's the...
So the HANA table is expensive, and that is the kind of
differentiator. Yeah.
Some people do this operation without the table. It's a little bit more of a struggle, I think.
They just drop the leg down and have an assistant holding the leg?
Yeah, they put in a figure of 4. They're pulling harder on the bone. So it's more of a struggle. Some people, they have specific instruments to help them. I just think the HANA table, and there's other types of table that's just not the HANA table, help you basically as another assistant surgery.
So let me
But I think retractors gets better. Everything, you start, the instruments to put the implants in, implants change. Again, the technique gets refined via innovation, technique, and it's easier to learn now than when I learned it.
Yeah. And just for the audience to know too, like Dr. Matta was one of the early adapters from what was happening in Europe. And the HANA table I mentioned was used for, compound and complex femur fractures. And it has, and you correct me if I'm wrong, Juan, but each leg has its own mobility. Like you can move the leg into positions that when you make the incision in the front of the hip and you open that up and you sever the head, the femur now is accessible to you, and the HANA table protects the leg in a very good position that you can adjust while you're working or need exposure to the pelvis or those kind of things, right? That's my understanding.
Allows you to put traction, allows you to put flexion, extension of the hip, abduction and adduction, and rotation. So you can control a lot of
complete freedom. Yeah.
Yeah. And now, like I tell innovation, there's companies now that are coming now with like nomadic robotic tables where you push a button. I want 45 degrees external rotation. Boop. So now you don't have to have somebody manning the table.
Now, you also integrate some robotic into your surgery. When people hear that, how does it play out in something like the hip replacement? So the incision's made and the dissection's made, the femur gets exposed. Where does robotics fit into that?
So people have a misconception about robotics because when people think about robotics, automatically they think less invasive. In joint replacement, it's a little bit different. Robotics and hip replacement, the value is that it can get you where you want to get. The exposure has nothing to do with the robot. The technique of exposure is purely up to the surgeon. But what the robot allows you to do, if I want to put this acetabular component of the cup in these angles and in this position, the robot can get you there within 5 degrees of accuracy. which if you're doing it manually, you may not be as accurate. So that's the added value. And also it gives you information in terms of leg length and offset. So basically the value is in
Precision.
helping you with the precision of the reconstruction. Yes.
Now, you also use it for the stem and the femur as far as... No.
The stem is manual, but once you get the stem in, it gives you the information. Listen, you started here, now you're 5 millimeters longer, you've added this much of offset. So it gives you information that allows you to make decisions intraoperatively.
Yeah, so let's just do a quick summary of what the procedure is, because now it's so quick. And, I felt like I went in and then I was done and I walked out. I mean, it was amazing. So we're coming in for surgery. We have typically now, the other thing was doing a block or an epidural, right? Are you guys doing epidurals now to prevent?
So what we do is a single shot spinal. So an epidural is when they put a catheter, like when you're giving birth.
Yeah.
They put a catheter and they can titrate the medicine.
So this is more epidural.
What we do is a spinal. They just give you one single shot. And what we're injecting now is a anesthetic that only lasts like an hour, 15 minutes. Because we want you to wake up early on your legs and we can move you.
Yeah.
So
does that prevent a lot of the noise getting up into the brain as well, the central nervous system? Does that make any difference? I mean, I was reading something the other day that pain is obviously a conscious response to neuroinformation coming up from somewhere that's been injured or trauma. Does it seem like they need less post-medical care if you do the spinal?
It hasn't been shown. You can find papers that show that and papers that are not. What we're doing differently now, though, is there was a recent medication for pain approved in the FDA now. It's the first medication that's been approved in the US for like the last 20 years. It's not an opioid, and it acts in the peripheral nervous system. I don't know if it's in the sodium or calcium channels. So basically, it's preventing that signal.
Message.
Yeah, it blocks the message to going out of your brain. And we're having very good results. It's not an opioid. It doesn't have addictive issues or all the side effects that opioids can give.
It's not a kratom derivative, is it? What is it?
It's called Journavx or
Journavx.
Journavx.
Interesting. Well, I love anything that obviously minimizes opiate use. And you and I have also talked about that as far as just the main thing is getting people to be able to sleep, especially with the knee replacement, is getting them to sleep at night. And
But to your point, some people after any surgery, it could be any surgery, this nervous system stays kind of wounded up and the message doesn't stop. And those patients become a big significant problem to control their chronic pain.
Okay. So we do a spinal injection. You also did a cocktail for me before. I don't know if
we give Tylenol before surgery. We also
like Lyrica or something.
Lyrica and Celebrex.
Yeah.
We give before surgery. That's called preemptive analgesia, meaning try to minimize the need of post-operative analgesia. And then also in surgery, we give people steroids. And steroids, they've known to help with pain and post-operative nausea. So those are given before surgery.
Okay. And I think not everybody does the same protocol as Dr. Suarez. So it's also finding and talking with your surgeon, but it's like understanding what are some of these other things that are being done by your surgical team to be able to minimize discomfort, optimize recovery, get you back on your feet, minimize the reliance on things like opiates that are often used in the past for these type of surgeries. Let's go back into the surgery now. So you've got them on the HANA table. They're organized. You've got your films, everything you need. You open, and we talked about the front of the hip. You still dissect in between when you talk about the dissection.
The incision. So you're making the incision over the fascia, over the tensor muscle.
Tensor fascia, yeah.
And then you're doing the interval between the tensor and the rectus.
Rectus femoris, yeah.
Yeah, so you're going in that interval, and then you're right there. Once you're in that interval, you are right in the hip joint.
Yeah.
There's
Are there any kind of risk in that area? I mean, you basically make sure you stay away from the femoral artery and you're good.
Yeah, the neurovascular bundle is quite medial. The one thing that is not uncommon is there's a nerve called the lateral femoral cutaneous nerve, and it's a peripheral nerve. And the course of that nerve is very variable in people. It's been described anatomically. Some people have more of a one nerve. Some people have fan-like nerve. But in that area, you're going to damage some of those nerve endings. And what happens, you get a little bit of numbness in the thigh.
Yeah, I remember having.
And it's hard to predict because people's anatomy is different. But that's
normal with any surgery, right? I mean, some peripheral nerves are going to be hit and they'll come back. And so then you open up, you have the visibility, you open the capsule. You're now looking right at the neck of the femur.
Yeah. And then you make the neck cut based on your preoperative plan, because obviously that neck cut depends on your anatomy and the size of the stem that you're going to use. And then that's the first thing you do. You make the femoral neck cut. Once you make that, then you're exposing the acetabulum first. And it's all about retractor placement and exposure.
Right.
And then you start reaming the acetabulum or using what layman term would be like cheese graters of different sizes to prepare the bone.
That's a good description. That's a good description of reaming.
It's like yeah. And then you're taking that bone out. And what you want to do is you want to ream all the sclerotic bone from the arthritis so that you have a good bleeding bed.
Yeah.
And then you put a cup in, and the surface of the cup is typically 3D printed. And it's a surface that's very porous. So
bone will grow into it.
Friction. Yeah. And the bone grows into it. And that will provide the biological long-term fixation.
Oh, that's so much better than yeah. And that's material is made out of what? Is that also titanium?
That's titanium. That's titanium.
Yeah. And that's the same kind of thing that would happen with the stem that goes down the femur.
Exactly. So once you get the cup in, you put the liner in, and then you do the exposure of the femur. And that is the hardest part of the anterior approach, exposing the femur enough that you can work on it. And when I started 20 years ago, the femur exposure had to be very generous because we didn't really have the instruments to do anterior approach. But over the years, we developed, the instruments have gotten so good that now we can work in tighter windows and accomplish the same reconstruction.
Yeah, yeah. It's all about the tools, isn't it?
Yeah, so that's why now it's easier to learn, because if you have the right tools, it makes the job a lot easier.
So anatomically speaking, for the audience, if you think of the femur is the thigh bone, and it comes up and it has a neck that is between the major part of the thigh bone, and it comes in, and then there's the head, and the head is the part of the ball and socket. So the ball that goes into the acetabulum, that's the socket. So just making sure we're hitting all levels here of understanding what this procedure is doing. So now comes the really fun part, and that is hardware. So like choosing hardware. And even in my little, jaunt around the country looking for a surgeon, each of you had a little bit different feel on which brand and which combination of hardware to do the replacement. Would love to hear your thoughts on that.
So, it's a matter of what you're comfortable with. And typically people use what they're trained on. They get used to those instruments because the implant comes with an instrument tray and stuff like that. I mean, you can customize things, but typically people use what's good in their hands.
Mm-hmm.
But then a company comes out with something a little bit more innovative and better, so then you start using that. So it really depends on the instruments, the implant, the track record of the implant. But now every company has DA or anterior approach friendly implants and instruments. If not, they're falling behind.
All right, so what I don't want you to tell me today is that there's something incredibly better than the hardware that I have inside my own body. But
no, the hardware that you have has very good long-term record, so you don't have to worry about that.
That's good. So I know that the trays have multiple testing sizes and things to make sure that you can get the right angle, you can get the right pitch, you can get the right length, all of those things being done now. How likely is it that somebody's more than a quarter inch off in the leg length with the total hip replacement? It used to be common.
In a posterior approach is common.
Yeah.
Because on an anterior approach, the beauty of it that you can use fluoroscopy intraoperatively, and you're measuring with computer navigation systems or robotics. And, it's very rare that somebody that is capable in anterior approach to be that off.
Yeah.
But in the posterior approach,
It was common.
you couldn't use those technologies because the patient's on his side. So using that technology was harder. And it was not uncommon to have somebody be a quarter of an inch longer.
Yeah.
But an anterior approach is rare.
It's rare. Good. That's what I wanted to hear. Because I remember seeing a lot of the posterior approaches would come in. And maybe to put it into the right framework, we talk about things in osteopathic treatments of pelvic torsions and sacral this and leg length discrepancies. And so, we know that leg length discrepancies could come from a number of different things. But when we were truly measuring, leg length, we would see occasionally with the post-op posterior ones that we would have some leg length discrepancy. And it was sort of expected that that was a risk factor of a posterior approach. And so I know that I don't. So my legs are perfect except for the knee, and we'll deal with that another day. But let's go a little bit into a couple things before we go into the rehabilitation of it. Just looking at different patient populations. So, for example, with me, we had titanium stem, titanium cup, polyethylene, or whatever it's called, was the
liner.
The liner, and then I have a ceramic head.
Mm-hmm.
Any thoughts on that combination, why you like that combination more than maybe just that's how you were trained? Or
So you've always tried to find the right combination that lasts the longer, right? And in doing so, we've made mistakes. And one classic example, when we started doing metal back in the 2007, 5, we were doing metal because we thought that metal doesn't wear and it'll last forever. But what we didn't know is that we were introducing a different problem of metallosis, and it's a disaster. So we bailed from that. The other option is ceramic on ceramic. One of the fears of that is this: it can create. We started squeaking. We started getting patients with squeak, and that kind of, drew us off of that. So the more logical one is if we can get the plastic better and use ceramic. The ceramic is very hard, so it doesn't scratch. So the surface stays very smooth and it won't wear the plastic. Then that would be the safest and durable combination.
And I know they had a problem with the plastic one time. There was like a whole...
Yeah, because this is getting very in the weeds, but the sterilization of the plastic is very important so that it doesn't oxidate. Because if it oxidates based on the sterilization process, then it doesn't last as long.
It can wear down.
We're having problems with that recently. There's a company out of Gainesville called Exactech that it's been a disaster with their plastics, and we're revising all those patients now.
Yeah.
So
I've heard of some of that, and I've seen a little bit. I didn't know the specifics on it, but I know, again, this is just for the general public to know, like really picking your surgeon, talking to them and asking them questions about the hardware, the procedure. You're the consumer, and build that relationship with them, and be aware also that sometimes things happen that are outside of your control. You don't have control over that. And then you find out that there's a recall on hardware that you had no way of knowing about. You used your best judgment, and sometimes that happens. And I'll conclude that by saying that 98% or plus of people that have a total hip replacement, anterior lateral, are happy campers that are back living their life full on, doing pretty much everything that they had done before with, no limitations.
This is the best surgery. The European journal Lancet, which is a very respectable journal, their cover a couple of years ago they stated that the hip replacement was the operation of the century. That's how successful it is.
I'm going to share another study with you. Did you know that Pilates is now, with multiple systematic reviews, and one that just came out in the British Journal of Sports Medicine, deemed it as the #1 intervention for low back pain? So,
really?
Yeah.
Wow.
And it's now the fastest growing exercise in the industry of healthcare.
That's why my wife doesn't have back pain.
So you and I together, we got a good thing. Total hip replacements and Pilates to prevent it or to rehabilitate it. We can work together to do some good things. Speaking of rehabilitation, let's go ahead and jump into that. So basically, once you got the hardware in, you close the capsule, basically close up the wound, and we're done. That's taking you now, like you got it down to 45 minutes to 60 minutes.
Yeah, like within 40 minutes, the implants are in.
That's amazing. That's amazing. I remember watching it when it was posterior, and I had privileges to go into the hospital and to see a number of surgeries quite often. There's nothing like really understanding and seeing the surgery to be able to understand how we can best rehabilitate, or the time that we need to allow for healing and repair, understanding the difference between a posterior where they have to repair the muscles that were cut to get access versus an anterior approach where no muscles were cut. It was a dissection and you're dealing with some healing, but it was nothing grave. Where do you see things happening now from the rehabilitation of the total hip?
Well, one of the things with anterior approach is that I tell patients is faster doesn't mean better after a hip replacement. You need the tissues to heal. I tell patients we need the inflammation of the surgery to calm down. And we need to take it easy for the first 3-4 weeks. And then after that, you start listening to your body. But all you need to work on in the beginning is mobility, bringing the inflammation down, walking, and that'll get you to where you need to be. Going in and being very aggressive since day one, that doesn't get you anywhere. That's just probably going to keep you in a cycle of pain that we want to avoid.
Yeah. Yeah, and I was very careful. I mean, I, of course, had the desire to do that, but I was good and didn't. But I will say one thing, that I've been looking at it just because of my own personal experience to a lot of my patients that I know have total hip replacements. And this is something that I would love to dive in a little bit deeper in the future, is thinking of this long-term effect of giving people body awareness. Another question I have for you. How many people have their capsule intact when you sew them back up?
I would say about 75% of people, I save the capsule.
Okay.
I mean, it's not like we're peeling it off of the bone and then we're sewing it together. It's not an anatomic repair per se. We get it in the vicinity of where it belongs, and then the body heals it.
Yeah. And I mean, everything, when you think of neural feedback, coming from mechanoreceptors, is all adaptable. So it's going to adapt based on load and usage. The question I have is for those of us that are in that 25% that don't have a capsule, what happens physiologically? Do we make a new capsule? Does Scar Tip create a capsule for us?
Definitely. When you go back in these patients, the body forms a capsule.
And it's just it's a fibrous capsule now? It's not, okay.
Yeah.
Yeah, I don't know why I didn't ask you that before. I was thinking like,
when we say that we take the capsule, we don't take the whole capsule. We create a window, but like for example, the posterior capsule is totally intact. Okay. It's more of an anterior-inferior window that we create.
Wow, that's good. All right, I got a couple more myth busters, and then we can be done with this podcast. Okay. Do X-rays always predict when a total hip replacement is needed?
Well, it's like what I tell patients is I treat people, I don't treat X-rays, right?
Thank you. Thanks for saying that.
The X-ray shows significant degeneration, and my exam and talking to the patient all points to that as the source of the pain, then yes. But, it's not infrequent. I see a patient with bone on bone on the hip, and I talk to the patient. I'm like, your pain is not coming from your hip.
Yeah, it's not intra-articular.
We need to investigate this a little bit differently.
Yeah, I think that's so important, is to differentiate extra-articular pain coming from outside the joint. How do you differentiate that? I know for me, the big eye-opener was I did get an injection intra-articular.
Right, that's a great tool that we have.
And the pain was gone.
The hip. Yeah, if you inject the hip with numbing medicine and the pain goes away, at least temporarily,
at
least you get a sense that that's the source of the pain. But if you inject the hip and they tell, listen, I got no relief, then you got to worry about it.
Yeah.
But yeah, it's not, a lot of people have back issues that they interpret as hip pain, and you got to
differentiate it.
Yeah.
Next question, osteoporosis. So you obviously deal with an aging population. I know it's getting younger and younger, but when we're looking at people with osteoporosis younger and younger as well, does anything change as far as the hip replacement for somebody that has bone density issues?
So if the bone quality is poor, one of the things we do is we cement the stem, not the socket, but the stem. The incidence of fractures of the femur is much higher with cementless stems than with cemented stems. Obviously, because you're pounding that in and you want a tight fit because that thing can't move, so the bone grows into it. So on people with poor quality bone, instead of preparing it aggressively, we prepare less aggressively. You cement the stem, incidence of fractures much lower, and then you avoid problems because of the bone quality.
Okay, so it's the cement that would be the difference in poor bone quality. Man, that's all the questions I have for today. We've answered so many of them. The one that blows me away the most is the over 50 stat.
Yeah. And I want to make sure the audience understands this. When you get a patient like Brent, those are the ones that keep you up at night because he's so in tune with his body that you're like, man, I know what I can do with my hands, but I don't know if he's going to be happy with this or not because you're like very in tune with your body. You're very vigilant about everything that's happening in your body. And I was very satisfied that we gave you what you needed to get on with your life.
Yeah, such a good outcome. Dr. Suarez, anything that is like lighting your world right now that you're passionate about?
I think what's lighting my world right now is more on the knee side, something called kinematic alignment. It's a way of trying to recreate the anatomy how it was before it was diseased. It goes against the grain, but we're seeing very good results. And I think I see kinematic alignment as the same challenge to the dogma like anterior approach was to hips. And we'll see if the data pans out, but I see some really good potential and cool things coming that way.
Good. Well, I'm waiting for you to get that before.
Yeah, we can have a conversation about this offline for sure.
Or we'll have another episode on the total knee. So we'll
for sure.
We'll be building this
awesome.
up. That would be great. Dr. Suarez, you're awesome. And you're awesome in the operating room as well as a friend. And I appreciate you taking the time today to meet with us. And as I always say at the end is live aligned and be kind. And so you contribute to that in your surgery and your kindness, both of them. So thank you, Dr. Suarez.
Well, thanks for having me, Brent. Appreciate it. It was fun.
All right. We'll talk soon.
Okay. Bye-bye.
Thank you for joining the Live Aligned podcast. If you like what you hear, please let us know by leaving a review on your favorite platform. If you have comments or questions, please leave me a message at drBrentAnderson.com. You can follow me on Instagram at drBrentPT. To take a deeper dive into the science of movement, check out my new book, Principles of Movement, available on Amazon. Live Aligned Podcast is produced and edited by Gabe Anderson. Music and sound designed by Delver. Special thanks to my team, Elizabeth Jimenez, Melissa Pereda, Cesar Maya, Gary Bentz, and Charlie Zuckerman. I also want to thank the team at Polestar Pilates for sponsoring and supporting us with technology, marketing, strategy, and much, much more. Thanks again for listening. Live aligned and be kind.